Hello and welcome back. I'm Sam. I'm here with my co-host Ashley. This is All Bodies, All Foods, and we are doing part two, all about treating ARFID with Jaclyn. Welcome back.
Thank you for having me again. I'm so excited to cover some more information and to give some support to the viewers for sure. So I'm really excited.
Well, thank you so much. I know halfway through our part one with you, we realized pretty quickly we
Yeah,
needed
we
a
did.
part two because there's so much to talk about. And
Yeah.
ARFID is one of those lesser known eating disorders that it really doesn't get the attention it deserves. So we're going to give it some attention. We're going to give it 2 episodes worth because it's needed.
Yes.
Great.
So we covered a lot in part one. Folks, if you're listening in, if you want to go back, if you haven't listened to part one yet, we talk all about the diagnostic criteria for ARFID, the
hmm
subtypes, who's at risk, signs and
hmm
symptoms. I mean, it was like, I think, Ashley, you called it a crash course in ARFID.
It was
It
indeed.
it really, really was. And so all about ARFID if you're just interested in learning about the diagnosis. And then also we talked about what sessions look like with you in residential
hmm
treatment, what to expect, all that exposure work you do, all the
hmm
progress that you can make in
hmm
4 or 5 weeks, an amazing amount of
Yeah.
progress in
Yep.
such a small amount of
Yeah.
time. But for this episode, I thought we can dive into a little more about treating ARFID within a treatment team, a little bit more about what exactly are the differences between getting treated at a residential center compared to an outpatient setting, because you
hmm
work at both. You
Yes.
work with people in
Yeah.
that 24/7 support residential setting, but also you have an outpatient practice. So there
Yes.
might be people wondering what's the difference? What would benefit me, or
Right.
my child? And then all about the family. How can families and
hmm
partners support their loved one? We're going to dive all into that and
Yeah.
yeah, hopefully help people out there who are wondering, what can I do differently to support my loved one?
Sure.
Yeah, so let's start with the levels of care.
hmm
You
Yeah.
are our expert, our ARFID expert at Spring Lane at our residential program in Philadelphia, and you have this private practice where you work with patients. What are some signs that someone might benefit from a residential treatment program compared to an outpatient setting? Like, how do they
Good
differ?
question. Yeah, good question. I have had the privilege of working, in the residential realm, but then also training a lot of our non-residential sites or our outpatient sites in the Renfrew system. And then, yes, I also have a outpatient private practice too. So
hmm
I have
Right.
been able to treat ARFID at all levels of care,
At
um,
all levels. And for
at
our
all
audience, that's
levels.
residential,
hmm
it's partial hospitalization program, it's
hmm
intensive outpatient and the
hmm
outpatient level.
hmm
Correct. Yes.
Yes.
Yep. Back in the day, I did when I lived in Nashville, when I moved to Nashville for a little bit, I was able to work at our non-res or PHP site, which was awesome. So I
Jacqueline, I
Wow.
didn't
really,
know you worked
yes,
there. That's where
I
I started.
did.
Oh,
I
wow.
did. I did work there.
Ah,
Yes. I worked there for a short amount of time only because I just had had my second child. So I was
okay.
kind of on maternity leave at that time, but yeah, I love Tennessee and I love that site. And it
Yeah.
really gave me a lot of insight into what happens after a patient leaves residential.
Yeah.
What
Yeah.
happens
Right.
afterwards? And then, then I opened up my private practice about 6, 7 years ago, and I specialize in ARFID, obviously other eating disorders as
hmm
well, but primarily ARFID. So again, I've had that privilege of seeing a patient sometimes all the way
mm
through.
That's
So
cool.
starting at
Yeah.
res
hmm
and then working their way down to PHP, working their way to IOP, and then seeing me at my outpatient practice at the same time.
Right.
So it's amazing because for so many years of
hmm
working at Renfrew before ARFID came around, I primarily just worked in a res site, and then boom, I didn't know what happened afterwards. I would see them
Yeah.
at the reunion once a year, which is always wonderful, but I never really got to see what they like, what tools they were utilizing in their everyday life that we
Yeah.
had
Yes.
learned and talked about in res.
And then the
So,
progress they continue to make,
Hmm.
right.
which, we don't get to see often, but
Yes.
that must be so amazing to
It's
see
Yeah.
amazing.
the
It
progress
is
the
so
whole way
amazing
through.
the whole way through.
Yeah.
And what's interesting too, I notice is when somebody is in residential, then they step down to a PHP where they are living at home. So I get to see them in their natural environment
Yes.
and
Right.
Yes.
how different they present.
Yeah.
Much more
Mm,
relaxed, you know.
yeah.
It's on a different level. I mean, treating outpatient versus res is very different. Like the level of, there's not as many obviously rules and guidelines to their life outside of here like there is here. So you do get to see them in their natural environment, and you get closer with the family as well, which is really, and their
Mm,
loved ones when you're treating outpatient. But going back to your question of like the difference, like how do you know if a patient needs residential versus other levels of care for
right.
Mhm.
ARFID? So what comes to mind when I think about this is when I've had a patient at my practice who is a new patient, has come to my practice for an assessment, and I notice that it's what's another great reason about working here is I know very quickly what level of care is going to support them best because I know
Yeah.
all the levels of care. So I think about like the medical piece of this, how are their labs looking?
Mm-hmm.
So I'm looking at their labs, I'm talking to their PCP or their pediatrician, and their weight, obviously, that, we have to consider their weight at the time and how much nutrition they're actually getting in, they're intaking.
Hmm.
So I think about that. I also think about what the family is able to provide for them. Like, are they able to really support them at an outpatient level of care, or do they
Hmm.
really require the support that residential can give them?
Right.
Hmm.
Right.
I also look at, how many sessions do they need a week with me?
Hmm.
Residential, they get 3 a week. Outpatient, they get 1 a week.
Mm,
So,
mm-hmm.
Yeah. Wow.
can I really support them and their work? And,
Hmm.
when I'm seeing them one day a week versus 3 times a day for
Right.
sometimes 4 days a week. I
Right.
mean, four times a week,
Yes.
3 to 4 times a week. So, for about 30 minutes to an hour each session. So I consider all of that, and also obviously like what their responsibilities are in the outside world. Are they working? Are they at school? Are they able to take time away to go to residential? So there's so much to consider when you're having
Hmm.
that conversation with the family and the patient about possibly needing a higher level of care.
Hmm.
Right.
So there's a
Right.
Hmm.
lot to consider.
Mm-hmm.
And, sometimes it takes us saying, we're going to try this out. Let's see
Yeah.
how you respond to
Yeah.
the exposure therapy.
Yeah.
And I've been doing this a long time, so I quickly realize, this is going to take a while for them to start taking risks with me. This might
Yeah.
take too long. So residential would be better for them because naturalistically they are taking risks here in residential every time they go into that dining room. They're
Right.
taking risks, food risks. So
Mm-hmm.
they get more acclimated to it when they're in residential than you do outpatient. So you have to decide really how are they responding to the treatment and the
Hmm.
interventions. And if they're not really
Hmm.
responding well to them outpatient, it's a pretty big sign that they need a higher level of care and more support.
Mm-hmm.
Right.
So many
Right.
factors go
Yes.
into these assessments. And just a reminder to our audience, if for any providers out there or family members, Renfrew will do an assessment and help you not only figure out what the diagnosis is, but what level of care best matches
Hmm.
what you need based on everything you said, Jaclyn, like medical issues, are there psychological issues? on top of the ARFID. Oftentimes
Right.
there are eating disorders so rarely travel alone. Are there issues with you getting support? Is your family
Right.
really able to eat meals with you and support you every single day, every single
Right.
meal? And it's
Hmm.
not always realistic, but getting the support of the community can be so helpful in residential too, like
Oh my
meeting other
gosh.
people who have ARFID.
Oh
And
boy.
I
Yeah.
mean,
That,
I'm sure people maybe come into residential and it might be the first time in their lives they're ever meeting someone else who also has ARFID.
yeah.
That does, yeah. And I also do consider, I know the part when I talk about the unified treatment model a lot and the tools I use from there in ARFID treatment and the emotional piece of all of this. It's not just about sensory issues and, there's a lot of fear involved and anxiety. And
Mm-hmm.
I consider that too. Am I going to be able to provide enough emotional support to them
Yeah,
um,
Mm-hmm.
in the outpatient world as opposed to coming here and getting all those wonderful tools
Mm-hmm.
that they get in residential. And like you said, Sam, connecting, oh my gosh, connecting with other people who are going through the same, the same issues
Mm-hmm.
they are. That's a huge factor too, I consider when we talk about, what level of care is appropriate for them. And
Right.
and sometimes I just say, listen, how about we give Renfrew a call,
Mm-hmm.
1-800 Renfrew, let's give them a call
yeah,
and let's get assessed. Let's see, because sometimes they
Mm-hmm.
need to hear somebody else say,
Yes.
this is the level of care you need.
Yeah.
exactly.
So
Yeah,
I really do push that. I really do because it's one thing for me to be telling them and the family. It's a whole other ball game to have Renfrew telling them what level of care is appropriate.
Yeah. Yeah.
exactly.
So, Jaclyn, thinking about residential and the work that you do there, I'm curious about the various like experiential groups that are done at the residential level. And is there anything, could you share with us what groups are done and then what groups really support our folks that we work with ARFID?
With ARFID. Yeah,
Yeah.
so the one, what I want to say about that is, we do take this team approach. When I have a
Hmm.
patient who I'm going to see with ARFID, we do take in consideration what groups are suitable for them. If they are formally diagnosed with ARFID, they don't have body image issues, so going
Yeah.
to a
Yeah,
body image group isn't the best idea for
Hmm.
them all the
right,
time.
right.
So I work with the therapist because the therapist works with the patient to determine what groups they should be going to throughout the week. So I put my 2 cents in a lot of times and say, based
Hmm.
on my assessment, I don't think
Hmm.
this person is appropriate for this group. I think they
Hmm.
benefit more from this group. Um,
Hmm.
but what comes to mind is, when we have an ARFID group. Like I think I mentioned that in part one. We actually have an ARFID group
Hmm.
where we are working together. And sometimes I'm teaching them how to cook some of the foods that we are trying. So what comes to mind is there's these Kodiak cups that I'm a huge fan of. They really push the protein. Texturally, they're very easy.
Hmm.
And they just require water, stirring, and putting them in the microwave. That's it.
Hmm.
Oh,
But
wow. Yeah.
making sure that the foods that we're trying really make sense to their life outside of here.
Hmm.
And can they really, like, are they really realistically going to be cooking these foods? So I
Mm-hmm.
want to make sure that when they're prepared for going home, so they will be in the kitchen with me sometimes cooking and preparing things. I'll have them do maybe putting the water in the cups and stirring, and I'll bring it to the microwave. So that's really helpful. We do that during the ARFID party a lot of times.
Yeah.
I think about too, like the T stage groups
Hmm.
with the unified treatment model,
Yeah, our
when they get to T stage.
our transformation
Yeah,
groups. Yeah.
transformation groups. And I'm lucky again to be running some of those groups again. So that's all exposure based.
Yeah.
Yeah.
So what's
Yeah.
really cool about that too, though, is that, my ARFID patients get to do the exposures very early on in their treatment, which is different from the other patients. But by the time they get to the T stage groups, they're already experts in exposure work.
Yeah,
Yeah.
But
totally.
those groups are so helpful because you can go to the grocery store with your therapist. You can go on an outing where you're going, maybe you're going to Target and you're walking down the an aisle that typically you avoid, maybe
Hmm.
due to texture reasons, or if it's a medical based subtype patient, they're afraid of having an allergic reaction to peanuts. So maybe they avoid the peanut butter
Right.
aisle,
Right.
Mm-hmm.
So
Right.
we do offer these experiential opportunities for them, these groups to get them prepared for home. My patients really enjoy the art groups for sure. I mean,
Hmm.
they love the art groups
Hmm.
because our art therapist does a wonderful job of incorporating sensory work into the art therapy groups for my
Oh,
patients,
cool.
That is
which
really
is
cool.
great.
Yeah.
Um, so him and I, Kyle and I will talk about, sometimes if we're sharing a patient and they're working on, they have this subtype, the sensory-based subtype of ARFID. I know that they're having a hard time with tactile aversions, touching
Okay.
things.
Okay.
Kyle can provide some of those tools and some like paint and
Yes.
clay and all of that, so they can continue working on building their sensory tolerance in these other groups too.
Right.
So,
That's incredible.
That
mhm,
really is, and it points out that like sometimes it's not necessarily about the intervention, but it's like the process of the intervention, right? It's just
Yes.
like it's them getting familiar with the texture and the feel of the different clay or the pastels. I feel like when
mhm,
I've done some creative arts group, pastels can bring up a lot of
mhm.
emotions for people because they
Sure.
can be messy and kind of get everywhere. So
Mhm.
that's really cool.
Yeah, the connection, I think I might have mentioned this in part one too, of the connection of their tactile experience. Of being able to touch something or have some sensory stimuli on their body, like clothing, for example, wearing
Oh
tight
yeah.
clothing, people may have aversions to that. But when you think about that, and you're like, okay, well, that means that there's aversions of something touching one's skin, certain textures touching one's skin. Well, the same applies to inside your mouth. You have skin
Yes.
in your mouth. So
Yeah.
Yeah.
it makes sense that a lot of those folks that struggle with tactile aversions also struggle with texture intolerances. So
Yeah.
we do see that
Yeah.
strong connection.
Yeah.
That makes sense. It makes
Mhm.
so much sense when you explain it that way.
Yeah. Yep.
Yeah. It's like we have skin all over. So of
Yeah.
course you would be experiencing some hypersensitivities.
Sure.
Yeah.
Jaclyn, you mentioned the team approach, which I think is so
Yeah.
important to talk about in
Yep.
eating disorder care. The standard really, no matter what eating disorder it is, we take a multidisciplinary approach. And the same
Yes.
is true when we talk about ARFID. So I was hoping you could say a little bit more about how do you work with the rest of the team when you're
Yeah.
supporting a patient?
Yeah, yeah. So I mean, I love going to team meetings, of course, treatment team meetings, where we discuss the patient in depth. And each member of the team is there to be able to talk about their goals for the patient, how the patient's progressing. Um, I really love going, and because I love bringing a OT perspective to the
Yes.
treatment
Right.
team.
Mm-hmm.
Right.
So, and the treatment team, it's funny because they all get very quiet when I start talking because
Yeah.
it's some material and some education that they haven't experienced maybe in their schooling or in their clinical life. So being able to, talk about the sensory impact
Hmm.
the patient has with eating is really important, and be able to describe what they're experiencing. Also, oral motor work
Hmm.
always is fascinating. I feel like to the treatment team of, talking about chewing and how chewing and swallowing really affects one's experience with food and eating.
Yeah.
And then the other thing that comes to mind is just I really take a developmental approach when it comes to eating, and I think about the skills needed to eat. And there's 32 steps to eating, like
Oh my
32
goodness.
required steps to eating
What are
something.
some of them? That sounds
Yeah.
like a lot.
Yes.
I would have guessed like three to
Do
five.
share.
Uh-huh.
I know.
Yeah, I mean, there's, the oral motor work and the sensory work too, the sensory motor work of, being for your brain to be able to processing what you're putting in your mouth,
Yeah.
and then being able to um, figure out what the next step is. So there's a lot of tongue movement. There's tongue lateralization that needs to happen from, moving food from one side of your mouth to the other.
Right.
There's patients
That's
that
so
come in here
true.
that had never developed that skill. So they're
Yeah.
only chewing on one side of their mouth. And then
Yeah.
that a lot of times dental issues start happening, unfortunately, when you are only chewing on one side of your mouth.
Oh,
So
like overuse type
overuse,
issue. Oh, I
yes, where your
see.
teeth are worn down. There's a lot of cavities on that side. The other thing is it definitely impacts pacing at a meal. So if you're only chewing
Yeah.
on one side of your mouth, you're only picking up saliva from one gland on the one side of your mouth and not the other gland. So
Oh,
you're chewing double the amount of time if you're only taking saliva from
Wow.
one side of your mouth.
oh my
Yeah.
gosh.
Yeah.
I
So
never even thought of
yeah,
that.
I
yeah, it's
know.
Yeah.
fascinating.
Wow.
Of course, swallowing, there's, a lot of skill that needs to be done with swallowing. So, what happens is if somebody didn't develop one of the skills, I need to one notice and assess that, and also come up with a treatment plan for that.
Yeah.
So that's incorporated into the ARFID work.
Wow.
So, and and sometimes the patient has no idea that they
Hmm.
didn't develop this skill until I bring it to their attention, you
And they
know?
could go for years. I mean,
Yes, their whole
years
life.
Yeah.
without realizing
Yeah.
this. Wow.
And like, their family or their friends or loved ones, whoever is like, oh
Hmm.
my gosh, why does it take you forever to eat? Like, I
Yeah.
get that a lot. I hear the patients say that people comment on how slow they are to eat. And then once I tell them, oh my goodness, like there's an oral motor issue going on. They're like, wait, oh my gosh. It's so validating. It makes sense to them now. And the good news is it can be treated. It can be treated,
Yes.
Right.
Yes.
so going back to the treatment team, just like you guys are like, oh my gosh, I haven't thought about that. It's the same reaction I get from the treatment team. And um, it just gives the treatment team a better understanding of the person as a whole.
Yeah,
Because
totally.
Yes.
without these assessments with what I'm doing, no one's going to notice that. No one's
Right.
trained, the therapist, the dietitian, no one's trained in this oral motor work. So, um, it's really fascinating and
Hmm.
it just provides so much validation to the patient. It really does. I
Yeah.
mean,
Oh, I'm
once you give them
sure.
an answer of what is going on and why
Yeah.
they've struggled for so long, it's like a weight is lifted
Uh,
off of their
Yeah.
shoulders.
right. It's like they
This,
get answers to questions they didn't
Yeah.
even know they they had.
Yes,
yeah.
yes,
Yeah.
yes.
Oh
This
my
is
gosh.
really making me curious
Mhm.
about, like, have you seen a lot of misdiagnosis then in the past as far as ARFID is
Mm,
concerned?
Yes, a
hmm.
lot.
Yeah.
Yeah, I'm
Yeah.
seeing it. It's hard because, you want clinicians, you want pediatricians, you want doctors to be able to diagnose this
Sure.
and all of that. But I see what's happening now is there's just surface level questions being asked to these patients. So,
Okay.
for example, are you a picky eater? Oh my gosh, yes, I've been a picky eater my whole life. Oh, okay. Do
Hmm.
you struggle with body image issues? No. Okay, it's ARFID. It's ARFID. I'm diagnosing them with ARFID. Like
Yeah.
does this interfere with your psychosocial functioning? Yes. Okay, ARFID. And then they get here and I'm like, I'm asking I'm digging deeper. I'm asking the
Hmm.
right questions. I don't want just the surface level answers. I really want to get to the root of this and what is
Mm.
impacting their eating. Could be many
Hmm.
things impacting their
Hmm.
eating.
Hmm.
Sometimes we realize this is somebody with OCD.
Yeah.
Yes.
They're
As yeah.
Mm.
picky
Yeah.
because of their OCD. So it's important to really get down to the root of it and know and be able to ask the right questions and know what to ask.
Right. And
So I wouldn't want us, as a therapist to like overstep here
Hmm.
and take on your role because
Hmm.
you've obviously been trained in this as an OT.
Yeah.
And would there then be like helpful questions that
Hmm.
like in addition to just the, like the simple questions, not that they're simple, but that you
Yeah.
mentioned, would there
Hmm.
be some additional questions that we could ask that would be
Yeah,
helpful?
I would say it's really being curious and there's no stupid question. Like
Yeah.
as a clinician, I think sometimes we think like we should know the answer to that. Like, why would I even ask that question? That sounds stupid of me to ask it, or like, I don't know. Like, no, like be curious. Like if
Yeah.
someone's saying they're having a hard time with their chewing, okay, like even if you don't know what to do with their answer, because a
Yeah.
lot of times I hear clinicians say like, well, if I ask the question and then they give me this answer that they're having a hard time with chewing, I don't know what to do with that, Jaclyn.
Yeah.
Like, so sometimes it's not asked. So
mm,
it's having confidence that ask the questions, and if you don't know what to do with it, that's okay. It is
Yeah.
okay. Just be very curious
Yeah.
of, oh, tell me about your chewing. Like take me through, say you're chewing chicken, like grilled chicken.
Mm-hmm.
Take what is that like for you? Like
Mm-hmm.
tell me what's happening in your mouth.
Mm-hmm.
If these red flags start popping up where you think, oh my goodness, there's something else going on here.
Mm-hmm.
That's where you would point them, consult with, if you're in the Renfrew system, I mean, the outpatient sites call me,
Yeah.
the
Yeah.
PHPs call
yeah.
me all the time. Jaclyn, I have this patient. Can I just pick your brain for a minute?
Yeah.
So use your resources, but it's really about digging deeper. And
Mm-hmm.
when, I tell the dietitians here all the time, our new dietitians, when they're learning about our ARFID treatment and they come and they watch me treat. After a while, I say to them, like, tell me what your gut is telling you about this patient. What is the feeling?
Yeah.
Does it feel like ARFID? Or do you think
Mm-hmm.
something else is going on as well? So it really
Mm-hmm.
takes a lot of digging on our part. And
Mm-hmm.
asking a lot of questions. I always tell the patients, I'm so sorry to be asking you all these questions, but I want to figure this out with you,
Mm-hmm.
so we work as a team.
Mhm.
Um, but yeah, I would just say to be really curious that if you, even if you don't know what to do with the information right then and there, still ask, still,
Mm-hmm.
because they want to get help, they're more than
Right.
willing to answer the questions.
Right.
But yeah, if
Yeah.
something just doesn't sound right to you, or you're kind of like, oh, that sounds a little different than what I'm used to seeing in our anorexic patients or patients
Yeah.
with other eating disorders, don't be afraid to keep asking questions, and then go use one of your resources
Yeah.
to get some more answers
Mm.
or some support, from a supervisor or from, I always tell everyone, just give me a call. You can pick my brain. Let's talk it out. I always
Yeah.
say, let's talk it out. Let's
Well,
Yeah.
talk it out.
I'm just thinking to myself, for certain patients, if you're only treating ARFID sort of with like exposure therapy and that sort of thing, but you're missing all of the oral motor stuff that could
Yeah.
really be interfering also,
Of
it's almost like
course.
you're only doing half
Half the work.
half the
Right.
Yeah, I
work.
always say that. You're only
Yeah.
doing half the work. And, that's why I say it's so important, when somebody's looking for somebody to help them with ARFID, making sure that you go to somebody who can treat it all. Like it's good to have a team around you. I always say it's so, I mean, outpatient, I tell the patients you really need you need a therapist, you need a dietitian, you have an OT, but making sure that there's somebody there that can do all the work and understands all the eating disorders. Because there's a big majority of patients that come here that struggle with anorexia and ARFID. So
Right.
you
ARFID
have
Mm-hmm.
to be
traits and yeah,
very
yeah.
careful, because you
Yeah.
don't want to reinforce, the other eating disorder with what you're telling them about ARFID. You have to be able to treat them both at the same time.
Right.
Absolutely.
So making
Yeah.
sure when you're, looking for a provider, you're asking the questions of, does the provider treat oral motor issues? If I have an oral motor issue, can I be treated by this provider?
Wow. Yeah.
Mm-hmm.
Do they have
Yeah.
Mm-hmm.
experience in other eating disorders as well?
Yeah.
Right. Right.
Can they do the emotional work as well?
Yeah. Yeah.
So I always tell my outpatient patients, it's not just about building sensory tolerance here. It's about doing the emotional work that goes along with it. And you have
Hmm.
to be
Mm.
able to address both. Or
Yeah.
again, going back to what Sam says, you're only getting half the work,
Hmm.
you know?
Such a good
So,
point. Yeah,
mhm.
The
yeah.
emotional and the sensory.
Yep.
Is there, I don't know. I know you said no question is a bad question. Are
Yeah.
there other like diagnoses that you see that co-occur
Hmm.
frequently with ARFID? I know you
Yeah.
mentioned OCD earlier,
OCD.
but
Yeah. OCD. Um, ADHD. I mean, we talked about the
okay.
four A's last time.
Oh,
I
the
was
four
Yeah.
A's. Yeah,
Oh
that's in
yeah, yeah,
part
yeah.
one, the
in
four
Yeah.
part
A's.
one. But ADHD I see co-occurring a lot. I mean, a lot. Autism, I'd say about 50 to 60% of my patients have a
That's right. Yeah.
autism diagnosis. Anorexia, like I see that happening later on in development, where
Okay.
Mm,
they struggled with ARFID from birth. And then, they get into their teen years maybe, and you know, they end up having anorexia as well. So they're having
Mm-hmm.
two of these eating disorders. And a lot of
Mm-hmm.
times they're very opposite of
Mm.
each other.
mm,
Yeah.
And it's a
mm-hmm.
Yeah.
war, they describe it as this big war going on
Oh,
between the two,
yeah.
where it's very easy to just say, forget it. I'm not doing it. I'm not eating any of it because, like, I can't
Mm-hmm.
eat this because of this, and I can't eat this because of this. You know what I mean? So it's like,
Right.
Mm-hmm.
again, going to providers that understand both.
Yeah.
Um, so I see anorexia, binge, sometimes bulimia, binge eating as well is something I see a lot in the pediatric population where sensory-wise, the only textures that they can tolerate is maybe carbohydrates, one
Okay.
to two textured foods.
Hmm.
Um, and then they aren't eating other foods, so the only foods they're eating are carbohydrates. So sometimes they just get stuck on one food group and then they
Mm.
end up overeating one food group because they're not, eating any other food groups.
Getting the
Right.
variety, yeah, that they
Right.
Yeah.
need. Yeah.
So sometimes that occurs.
And then anxiety, I think, was that an A?
Oh, anxiety, yeah, for
Yeah.
Yeah.
sure.
Yeah.
Yeah. I
Hmm.
mean, always anxiety.
Always
It's very
Hmm.
rare I get
anxiety.
a patient that's like, no, I have no anxiety trying new foods because if they didn't have anxiety trying new foods, they'd be trying new foods.
Right.
So, of
Right.
Right.
course, helping them with their anxiety.
Well, and also malnourishment plays a
Oh,
role. And
gosh, for
so I
Yeah.
always
sure.
say the malnourished brain is an anxious brain. The malnourished brain is a
Absolutely.
depressed brain. I
Hmm.
imagine, do you see depression also?
Yes.
Yeah.
Yes, I do.
Hmm.
Especially in my teenagers, I do. Because I think ARFID affects them socially so much, where they really isolate themselves. And, depression and isolation go together a lot of the time. So,
Hmm.
where they aren't, hanging out with their friends, they aren't attending events anymore, birthday
Mm,
parties, and that really takes a toll on them.
Hmm.
And,
yeah.
so I see a lot of anxiety and depression,
Mm,
especially in our teenage population.
oh,
Yeah.
yeah.
Because
It's so
that's where
hard.
people are noticing, like I think I talked about in part one, where I have a big at my private practice, I have a big group of kids that are like 10, 11, 12, 13 years old, like a big
Hmm.
group of them.
Hmm.
And, I asked the parents, well, why now? Why?
Mm,
Just out of curiosity, why did you seek help now? And they said it was too difficult to hide from their friends. Their
Oh.
friends are
mm,
noticing, in the cafeteria, why do you eat the same thing all the time? Or they offer them
Hmm.
something, hey, try this. And the kid, no, I can't do that. So then the friends
Hmm.
start asking more questions, where they, they're expected to go to like school events where they don't know what the menu is, so they are so nervous about going, like the food piece of it, that they decline the invitations. So they're not
Hmm.
showing up. And, their parents said, we can't do this anymore. We can't feed them before they go to birthday parties anymore. We can't, the excuses are running out.
Yeah.
yeah. Yeah. It's
Yeah.
Yeah.
interfering with
Oh, it
Yeah.
their
does.
happiness, their social
Yeah.
life. Yeah.
Sure.
Makes a lot of sense. I know I'm looking at the time and I
Mhm.
really am hoping that we can talk about families
Yeah.
Yeah.
Yep.
and how, I guess my question is, what are some of the ways in your experience where families maybe try to help, but
Yeah.
it's you sort of have to help them support their child
Yeah.
differently. Maybe we
Hmm.
Yeah.
can normalize some of the ways families respond,
Yeah.
but also how they can also,
Yeah.
support a little more effectively.
Yeah, I mean, what I want to say about families is like, one, there is help out there. I think
Yeah.
a lot of
Yeah.
times they think we're stuck, like there's no one that can help us. But
Hmm.
there is absolute help out there. And I know for a long time they might have been living with this for so long, trying to help their child, or their loved one, and didn't know where to go. Or like maybe
Yeah.
they're telling the pediatrician, but the pediatrician isn't taking them seriously of how severe their picky eating is.
Hmm.
No, we keep
Mm-hmm.
hearing they'll grow out of it. I mean, I the
Yes.
pediatricians say that often, and the
Right.
doctors, I'm seeing a shift, thank goodness, seeing a shift where they're saying, wait a minute, talk to me more about the picky eating. Like, how picky
Hmm.
are we, which is
Hmm.
wonderful. So and the other thing I want to say to the parents is like, this is not your fault either. I think a
Mm.
lot of times the parents blame themselves of, did I do this to my child?
Yeah.
Was there something I could have done differently?
Right.
Um,
Right.
and most of the time, no, there's nothing you
Hmm.
could have done differently, or, oh my gosh, Jaclyn, I think I've made it worse. I think I've really made it worse. And, I'm a parent. I get it. I have a son who's a picky eater. I get it. Um,
Hmm.
and you want to just help and you want to do the best that you can. But that's where professionals need to step in and give you as a family support. I'll tell them, listen, guys, like you're on break now. Let me do the work. Like you're done.
Oh,
You're on break.
yes.
Like let me do it. They're
Mm.
like, what? And I said,
Hmm.
that's it. Like I always give my patients homework. They always have homework when they come see me, but it's not hard homework, it's fun homework. But that's where the parents, the families can support is the homework that I give them, which
Hmm.
may be for them
Yeah.
to pick up a type of yogurt that we tried in session and they really enjoyed it. So the
Hmm.
homework would be for mom or dad or whoever to purchase that yogurt and try it
Mm.
Yeah.
at home. That's where you can support them.
Yeah.
So, yes, I tell them they are on break. It is my turn. Let me do the hard work. Um, and and again, it's not their fault. This is not their
Mm.
Hmm.
fault. We've learned that the sensory-based patient is born with it. They're born with their sensory system, just not all organized. Um, and again, not to blame themselves, you
Not to
know.
blame. I think that's so important. No matter what
Yeah.
eating disorder there is,
Yes.
I think the tendency is sometimes like, who do I blame? Is it their
Mhm.
fault? Is it my fault? Is
Mhm.
it,
Is it the doctor's fault? Is it,
right,
oh,
right.
is
Right.
it because I'm a picky eater? I get that a lot. Jaclyn, like,
Yeah.
is my child like this because I'm a picky eater? Like, did I do this? And
Yeah.
I say, I don't know. Like at the end of the day, like we can't spend a lot of time worrying so much about what should have been done, what could have been done. The focus is on what we're doing right now and
Mm,
what we
mm-hmm.
want for their future and what we're working towards and how
Right,
they can
right,
support them now.
Yeah.
So it's never
right.
too late to support now. So,
Yes, that's such good guidance. I'm just curious, Jacqueline, are there any like quick do's and don'ts that you have to teach
yeah.
parents or you like to teach parents
Mhm.
in the beginning?
Yep. Yeah. So just like any eating disorder, I mean, working here for years, I've always told the parents, like, and the loved ones and the patients, do not label food good or bad. Food
Mm,
is
Hmm.
mm-hmm.
food. There's
Hmm.
not good foods and there's not bad foods. Food is food. It's neutral. So I do a lot of times have to educate the families on that because they
Yeah.
have mentioned, my office, I'll hear them say the J word and my junk and my, skin crawls, the word junk, this
Junk,
junk
Yeah.
junk
food.
food. Yeah.
Because
Hmm.
Mm-hmm.
what happens with ARFID patients is like that junk food is their safe food, is
Mm,
something that they are
Um,
eating for them to survive. Like that's all they can do.
yeah.
So by
yeah.
labeling it something negative, then is easily internalized for them to
Yeah.
feel
Right.
that they're doing something wrong.
Yeah, like, am
We're
I
gonna
Yeah.
bad because I'm eating this? And
yeah,
it's one of the only
yeah.
things I can
The only
eat.
thing they can eat,
Yeah.
right? So
Mm.
educating them on all foods fit, I always say. Um, and making sure that when they do food exposures, like, I tell them you're on break, do not do a thing with them until I tell you to do anything with them. You're there to support them
Yeah.
with the work. But when it's time for the parents to start doing, and by the way, a lot of the times the parents are in session with me. So I'm modeling how I'm,
Awesome.
approaching the exposure work and what language I'm using, which is so
Yeah.
important. So I'm also treating the parents along with the child as well. So
Yes.
we're in this together. So just reminding them that, setting up a safe environment for them to try foods is a do. Make sure that you're making it fun. Like I always say, there's
Hmm.
one rule, and I tell the patients here, I tell the patients, outside of here, that there's one rule, and that's to have fun while we do this.
Mm.
Mm-hmm.
You take the pressure off somebody, they're more willing to do it.
Yeah.
Instead of them, a lot of our patients are people pleasers.
Mm-hmm.
So
Mm.
I don't put any expectations on them and I say, I need you to try this, but you do it any way you want. This is like
Hmm.
on you, you decide. But it's one of the don'ts to that is I would not have the kids trying food during meal times. If they're not
Oh,
ready to
okay.
try foods during meal times, I like to keep the exposure work separate in the
Okay.
beginning. So it might look like, they can always ask, like during dinner time, oh, I just cooked this, I baked this new dessert. Would you like to try it? If the answer is no, okay. Okay, not a problem. So always, you can present them with the food, but you listen to their no's because they may
Yeah.
not be ready for it yet. So I like to make the exposure work at home something separate, something fun, and if they can, something the whole family can do.
Yeah.
So we're not sitting
Mm.
there saying, okay, we're going to sit down and do exposure work now. Okay,
Right.
take it, here's your
Right.
fork here, make
Spotlight's
it,
on you.
spotlight's on you, we're all
Hmm.
watching
Right.
you,
Uh-huh.
but make it, like a family event. For example, I like to do Chobani flips with the patients. And, so they're yogurt, and then they have these fun little toppings that you can flip into your yogurt. So
Hmm.
I do this during one of our ARFID parties too, where I'll purchase a bunch of Chobani flips. So there's different kinds of yogurts, different kinds of toppings, and I treat it like an ice cream bar, So
Mm.
I'll tell the families, get a few of these, open them up, have everybody, taste the toppings, taste the yogurt separately, make their own yogurt sundae. Or
Yeah.
make your own pizza night where the goal is for maybe the patient to try one of like a topping that they typically
Right.
Hmm.
don't eat on their pizza. But again, making it really fun, not having a lot of expectations on them and taking away the pressure for sure.
Oh,
Those
yes.
really are fun
Yeah.
strategies.
Yeah.
When you said make it fun, I'm like, how do we do that?
I know. I love that you
Yeah.
call it a party for
It's a
one. It's like
party.
how
Yeah.
you label it really matters, you know?
Yeah, it's really
Yeah.
funny when we have the ARFID parties in residential. We're in our dining room and there's glass doors so people walking by can kind of see what's going on in the party. And we're all laughing, we're all having a good time. There's 30 foods out on the table, and the other
Mm.
Yeah.
patients who don't have ARFID, walk by and think, what are they doing in
What is
there?
that?
Right. What
We're all
group is
having a great
that?
time. Hey, what group's
Yeah.
that? I think I might have ARFID. you know. But again, really trying to make it fun. If really my biggest advice to clinicians, to families is, you know, taking the pressure off really makes a world of a difference. And I think
Yeah.
when you think about parents trying to get children to try food, I'm guilty of this. That you say, okay, here, why don't you try this? And everyone's looking at the person and they're like, no, I don't want to try it. And they're like, well, why not? Like, I just don't want to try it. Well, how do you like? They're like, I don't think I'm going to like it. Well, how do you know you're not going to like it? Like they're being interrogated a lot of times,
Yeah.
Mm-hmm.
and of course, there's a lot of pressure there. They're not going to want to try that. Like, they're
Right.
not going to be motivated to try it. So, taking that fun approach makes a world of difference. It really
Yeah.
does.
That's awesome. Okay, Jaclyn, we really are running out of time, but maybe one
Mhm.
more thing.
Mhm.
You label for us maybe a place that our clinicians, those that are providers that are listening here, can get more resources on
Mhm.
ARFID or learn more about
Mhm.
ARFID.
Yeah, I mean, I always go to NIDA's website, they
Okay.
always have up-to-date um, research for sure. Um, and this is going to sound like, I don't know. I mean, I say this and I worry about saying this sometimes of um, social media, like going to the right clinicians on TikTok or social media, because there's a lot of wonderful educators out there and therapists with experience that can walk a parent through what an exposure looks like and really just educate them. Again, you need to be careful with all social media, but I'm noticing a lot of wonderful, helpful information is popping up on those
Awesome.
platforms. But of course, there's the Academy of Eating Disorders is one. Um, Nita Renfrew, of course, go to our
Hmm.
website. We provide information on there. But research, there's a lot more research coming out now. I always say, like, after 10 years that a diagnosis is out, you start to see more research. All the 10-year studies, the 5-year studies are now published. So, taking a look at the latest research is always, helpful
Yeah,
to look at, especially with the clinicians, seeing
Mm.
how ARFID's being treated, the difference between how ARFID's being treated now versus when it first came out
yeah,
you know. But yeah, and then also your medical team, your pediatricians, your family
sure.
doctors, making sure that you are being very clear on your child's picky eating or your picky eating. Because again, when you hear the word picky eating, it doesn't sound that severe. And there's a difference. And I think I mentioned this in part one that you can grow out of picky eating, but you don't grow out of ARFID.
Hmm.
You need treatment with ARFID. You need
Mm.
Yeah,
help and support with ARFID. So when you're describing to a doctor that my child's picky, then they're like, okay, they're going to grow out of it. But
hmm,
being very clear with the doctor of, okay, I did some research. I looked this diagnosis up. It's called ARFID. Can you look over the criteria with me right now? Because I have a feeling my child may be experiencing this. So doing your research and really advocating for yourself and your child is so important.
Mm.
So
awesome.
important.
Okay,
That's why we wanted to spread more awareness about this
I
so
know.
people can advocate and have the terminology to bring
Yes.
Right.
to their doctor or,
Yeah.
bring to their child's therapist who may not be
Hmm.
trained in eating disorders and
Sure.
to make sure their child can get what they need. Jaclyn,
Yep.
I know we're out of time. If there's one thing you'd like parents and partners or any kind of support person to take away from this episode, what would you want that to be?
You know, I actually asked one of my patients over at my practice this question. If you were to talk to the families and you were to talk to
Yeah.
patients, what would you say? His response is, it is always so much scarier in your head than what
Mm,
is actually done, during
Mm,
the work. The work is easier than what you've made up in your mind.
yeah.
It's so much easier. And I think about that a lot, that sometimes you just need to take the risk and ask for help, ask for treatment. And again, like, I'm bringing the fun word up again, but it's hard work, but it actually is so rewarding and it actually can be fun, believe it or not.
yeah.
Yeah, it
Yeah.
can be fun.
So yes,
Mm-hmm.
that sometimes fear is just really standing in the way of something great.
Yeah.
So
Thank you so much,
yeah,
Jaclyn. We really
yeah.
appreciated you being here really for both parts. Thanks for
Oh my
thanks for being
gosh.
willing to come back and
Oh, this was wonderful. And I hope people who are listening, maybe this will help them,
yeah. Yeah.
reach out and get help. But there is help out there.
Awesome. And
Yeah.
yes, and thank you so much to all of our listeners. We really value you being here with us. Thanks so much.